And I was reminded of something very important in the break. Your wonderful hospital CEO, Denis Roy, made a point that I think bears emphasis and repetition right now, and I want to say it, that you don't have to be dying to deserve dignity. Yeah, I think that's a pretty profound point. And that really is one of the central issues in the culture of modern medicine, and that's really my expertise. Yes, I'm an emergency physician, and I am a, so I know a lot about emergency medicine from the front lines. I'm also the host of a radio show, and it is in that capacity as the host of a radio show that has allowed me to see and witness healthcare coast to coast to coast. I've become something of a medical sociologist, embedded on the front lines of medicine, observing and learning and interpreting what's inside the hearts and the minds of people on my side of the gurney. So as I promised you, there is end-of-life care, and then there is care at the end of life. And they are two different things, and I'm going to spend a few minutes talking about the latter, that is care that you happen to get at the end of life. And I'm going to use the lens of the culture of medicine and try to interpret a little bit about what you have seen and maybe you've had some objections to or some concerns about. But the one thing I want to say right off the bat is that Harvey and I are really speaking the same language. I would suggest to you that the root of, certainly in his talk, the root of the indignity of health care and the lack of dignity that leads people to despair and perhaps even want to end their lives prematurely at or near the end of life, that one of the key roots is a lack of empathy. And whether it is technology, whether we are focused on technology or the whiz-bang diagnosis and being able to make that save, that transplant, all of which, as Harvey said, is very, very important, we seem to have lost something in the bargain. And that is the ability to put ourselves in the place of our patients. And we will all eventually lose a pulse. So that's a really big problem. And I wanted to put that right off the top. In addition to that, I wanted to remind us of something that's very important. Now, you may think when you hear about palliative care that you have a long life, sometimes not as long as you would like it to be, and that you receive a terminal diagnosis, and then you have care, and then you go into palliative care, and then you die, and that everybody goes through that very, very orderly process. Well, certainly from my vantage point in the emergency department and my own examples from real life, from my own life and the life of my wife's family and some of my dear friends, I can tell you that life seldom goes that way. And so before you have palliative care, you have to be dying, and before you're dying, you have to have that diagnosis, and before that, there's a whole bunch of other things that are going on that are kind of setting us up for that outcome. And the first one is the thing that we talk about, the aging population. We've talked about a silver tsunami. We'll soon be talking about a boomer tsunami. Seniors are the fastest growing segment of our population. And the importance of that is not just as a cliche, but that a lot of people will be talking about it. And perhaps a critical mass, and perhaps as a direct result, there will be some changes. Maybe there will be some rising anger about some of the things, some of those indignities that Harvey talked about taking place in the healthcare system when you're on the receiving end. Not only will we age, now most of us will age well into our 80s, and that's the good news, but many of us will pick up one chronic disease after another, and in the United States, as I'm sure it's the same in Canada, I'm not aware of the statistics from Canada, but I am from the United States, that spending on chronic diseases accounts for 3 out of every $4 of the $2 trillion that are spent annually in the United States. And so we will get old, and we will accumulate all kinds of conditions, physical conditions, loss of hearing, mobility issues, arthritis, all of the diseases like cancer and arthritis and heart disease. We will have chronic pain. Sometimes it will be very difficult to manage. And I don't want to leave you with the impression that every pain can be managed perfectly, because it can't in some cases. And it leads, so that's going to be one kind of environmental issue around us. Then we start to look at the system. And this is a story that I have covered many, many times on White Coat Black Art. The new normal, the fact that millions of us don't have a family physician. Some of us now are starting to turn to nurse practitioners. But really, this is a metaphorical concept. It's not doctor-specific. It's not one specific professional that we're lacking. It's that we lack something called primary care, whatever that is. Primary care meaning looking after our more basic needs, helping us prevent diseases, or at least prevent recurrences or complications of diseases. And so what we have is a situation where there's a growing number of patients who have been euphemistically described as orphan patients. Orphan patients meaning that they don't have somebody to look after their primary care needs. And there are many ramifications of that. It means that they don't get their diabetes managed, so by the time they come to a hospital, they don't just have diabetes, they've got kidney failure from diabetes, or they've got not just hard to treat high blood pressure, but kidney failure as a result of that. They don't just have their first heart attack, but they have congestive heart failure, and I can go on and on and on. But they will end up coming to my side of the gurney. They will come in droves to the emergency department, and what reception will they receive? We speak in terms of verbs like slammed, inundated, swamped. And I remember a psychiatrist, a friend of mine, referred to it as a system in which patients are often seen as the enemy. And there are more of them, and a theme that I've discussed recently on the show on White Coat Black Art is this incessant drive to productivity. All of us who work in the hospital these days, but also in clinics, in family practices, are being asked to do more, to see more, to treat more, to learn more rules. There's this unrelenting pressure to learn more and more and more and more and more. And so we, in many cases, want to be able to do the right thing, spend extra time with the patient, and we're actually making a decision that I can either wash my hands or I can rush and see the next patient without washing my hands, and that'll save me a few seconds. Well, we know that that's a terrible thing to do. But I have some, and because I'm here to explain, not necessarily forgive, but at least explain the culture of modern medicine, I'm here to tell you that I've at times felt that pressure that keeps me from washing my hands. And why do I wash my hands today? Because I don't, I'm the host of a radio show on CBC, and I don't want people to say that Goldman doesn't wash his hands. So I have my own personal pressure to do it, but I know a lot of my colleagues don't, and the statistics in many hospitals have been dismal as a direct result of that. There is a representation for this lack of empathy that I just mentioned without talking about it. It's basically, empathy, there's sympathy and empathy. Sympathy has been described as a patient or a person is in the pit of despair, and the sympathetic person is standing at the top of the pit, on the edge of the pit, looking down and expressing some concern, some understanding, but not much more than that. Whereas empathy involves standing next to the person in the pit, looking up and saying, I've been there, and I can show you the way, or at least I can say I know what you're going through because I've gone through the same thing. Why don't we do that more often in healthcare? Is it possible that we're recruiting people who care more about marks? Yeah. That's the way we attract the best and brightest. And it gets continuously reinforced in medical school and very often in residency. Very often I would suggest, Harvey talked about the A, B's, and C's, his A, B's, and C's versus mine. I think there should be both. I think we should have both. But very often, I find in the culture of modern medicine, we treat the understanding, the ability to reflect with a patient, giving them time, as soft skills that we offer when we don't have the latest chemo or surgery or the latest hot new evidence-based drug to give to the patient. And it's a shame. And how we put that back is certainly one of the things that I want to be able to devote the rest of my career to. But it's a tough road, and I can tell you that the culture of modern medicine often resists new ideas, even old new ideas like that one. very quickly, I'm writing a book called The Secret Language of Doctors, and you can learn, and the thesis of my book is that you can learn a lot about the hearts and minds of health professionals by the slang they use. Argot or argot is a secret language used by various groups, including but not limited to thieves and other criminals. That's how it was originally formulated. It was popularized in Les Miserables, not the play, the Broadway show, but rather the book by Victor Hugo, and in it was the language of despair, and there's no more despairing people than young residents, and the whole idea of slang is that they can talk in plain sight, and you can be riding an elevator with them, and they can be using terms, which I'll give you a couple of them in just a moment, and not be the wiser to what they're talking about. They could be telling a whole story, but I will point out that it is not a story that's particularly empathetic. It's about their despair, not yours. And I'll give you one example. Certainly a lot of you have heard of the term GOMER, which stands for, actually there's a whole etymology, get out of my emergency room, the grand old man of the emergency room, GOMER pile. There's a whole bunch of them, but basically, GOMER refers to an elderly, often elderly patient with dementia who drools, who can no longer look for themselves, who's probably look after themselves, probably incontinent, and has done everything but die. And in fact, we have other, nobody uses GOMER because everybody knows the TV series Scrubs popularized it. So, once it becomes known to the public, it's no longer slang. So instead, we use witticisms like failure to cope or dyscopia. Dys means difficulty, cope, dyscopia. It's clever, and somebody who has a complete absence of the ability to cope with life's problems is known as suffering from acopia, which is the absence of the ability to cope. Well, one of the more cruel phrases that was brought to my attention by this guy, Donovan Gray, not that he uses it, is called, he's the author of a book called Dude, Where's My Stethoscope? He's an emergency physician from Winnipeg, was FTD. And FTD is not the florist. It is one of the acronyms, and the initials that stand for failure to die. And yeah, and I'll talk about the roots of that in just a moment. If you peel back the layers of medicine, you'll discover that we aren't particularly nice to elderly patients. And I'd say in some cases it's not because we don't like them, it may be because we're not well trained. That somehow the elderly patient that I just talked about, the GOMER, the FTD is not what we signed up for, and the proof of that is how many young physicians want to become geriatricians. Models like Dr. Samir Sinha, who you can see in the bottom left, he's one of just roughly 250 geriatricians in Canada. According to the Organization for Economic Cooperation and Development, the OECD, we need about 500 more of them. And I had the opportunity to interview 4 young doctors, Nathan Stahl, Amanda Gardhouse, Raza Nakvi, and Gillian Elston, and they told me, first of all, the good news was that they wanted to become geriatricians. The bad news happened when they started to tell their colleagues about their plans.
Was overwhelmingly negative. I was told that I was wasting my talents, that I was too smart to be doing something like that, and how could I pick a specialty where I wasn't actually helping people? This really bothered me. There is, I believe, a culture of ageism in medicine.
Amanda, you were nodding as he spoke.
I think we all share Nathan's frustrations in that geriatrics is perceived as very negative subspecialty.
Awesome. Do you agree with what you just heard?
I think absolutely. I think my kind of stumbling upon geriatrics is very different than a lot of my colleagues. I ended up filling in a block with geriatrics just to get it done because I just had a daughter and I needed some time. So geriatrics is light and do much was the reputation. I came on and I loved it. And as soon as I started telling people I actually liked it, I found myself defending myself a lot. And we need to try to get rid of that stigma that's so closely attached, I think.
Jillian, do you agree?
For the most part, but I wouldn't necessarily say that it's not a respected career choice. I think just the reaction that I get is, oh, that's so nice to be
So, and I'm saying this because we can candy coat it all we want, but if all but a few young doctors feel that way, then we've got a problem, and we have to address that. Whether we address it from without or within, that's an open matter of debate. But ageism is certainly one issue that's part of the milieu, the environment that we're talking about. I want to talk about another one that I think is related, and it relates in particular to that term FTD, failure to die, as if, why haven't you died already? You know, still here? You again? Why haven't you died already? And there is a thought that's swirling in the halls of the hospital that I'm going to get into in just a moment. But before that, as Harvey said, everybody's going to die. Everybody who has a pulse will eventually not have one. And whether it's today's diseases or tomorrow's diseases, we're all going to die. And the truth is, and the studies show, health economists tell us that we spend more in healthcare in the last 2 years of a patient's life than all the other years combined. Now, there are many, I think there's an implicit value judgment there that it's always wasted. It isn't necessarily always wasted. We look too much at survival in months and not enough at quality of life. And perhaps if we raised quality of life to being a worthy goal, we might actually decide that that was money well spent. But you get my point. And certainly we won't control healthcare costs unless we tackle that issue, and you're going to hear more and more about that in the years to come. Well, the concept that I wanted to acquaint you with at the end of life, and this is not a palliative care issue, well it is, there is a link to palliative care, I'll get to that in just a moment, is something called medical futility. And medical futility has no official definitions that have been broadly recognized. It's one of those things like that judge from the United States talked about, what was it, pornography? I'll know it when I see it. And what astonishes me is the ability of healthcare professionals to kind of call it, like shoot from the hip and call it, this is futile, why are we doing this? And what is important about that is that we often bring our own value judgments to the table in making that distinction. What are the pictures all about? Well, that's a flooded basement, and that's the implement. Using that implement to try to bail out that flooded basement is certainly meets my criteria for futility. But when it comes to human beings, it doesn't always work that way. I can tell you that my colleagues in the emergency department, probably less so in the intensive care unit, but certainly in the emergency department, those of us who have to make a split-second decision to intubate, to put somebody on a ventilator or not, are thinking more and more about whether we have the resources to do that. And it's if you have one patient at a time, it's fairly easy to say we'll make room. But what if we had 10? And certainly the promise of boomers reaching those years and being brought en masse to the emergency department has a lot of physicians very concerned and wanting to get some guidelines, want some guidance. And so that's another view from our point, our side of the gurney. Very often when you come to the emergency department, and Dan Lessard certainly wanted me to talk about my experience in the emergency department, you get sized up, and often very quickly. And if you're referred to the internal medicine team, chances are you or your family are going to be asked if you have advanced directives. Have you thought about what would happen if your heart should stop? Do you want CPR? Do you want a ventilator if you stop breathing? And that's important. Although, as we explored on White Coat, Black Art, it is very, very difficult to have that conversation mere seconds after you've told the family that you're worried that they may not make it through the night. And the problem here, the error is trying to meld those or weld those two conversations into one. You really have to let that digest, let that information digest and go away for some period of time, and then come back and ask questions about advanced directives. But we don't do that. And in fact, there's another bit of slang which I feature prominently in my book. It's called Getting the DNR. And getting the DNR means scoring getting the patient to, or getting the family to write down that in the event that their loved one stops breathing or their heart stops, that you agree that there'll be no resuscitation. And it used to be CPR or ventilation. Now there are multi-level DNRs that are signed that might involve, do you want intravenous fluids if you become dehydrated? Do you want antibiotics if you develop an infection? It can go on and on and on. And it can be very bewildering for patients and their families, particularly when they are just hearing this news for the first time. And you know, that's why I wanted to emphasize that, you know, would we all journey through life where we live a long time, we get a disease, it becomes a terminal illness, and at each step along the way we can contemplate it, then it would be a lot easier to deal with these issues, even though there are system issues like the lack of palliative care. There's not enough of it. But that's not the way it works. And very often this gets compressed into a very short period of time. And I can tell you that there is pressure to get a DNR. It's not coming from hospital administration. It's not. It's not a cost issue. It's not, we need the bed, let's get the DNR. No, it's more basic than that. It's a cultural thing. You don't get, if you're that resident, you don't get rewarded when you go back to what they call the bunker the next morning and say, I failed to get the DNR. On the other hand, if you get the DNR, it's often greeted with high fives. So that shows you the cultural bias that we have that is unexplored, unreflected, and it's something we need to talk about. Some of us don't even get to the point. Now, you know, maybe the family will say, no, we want a full code resuscitation, and even if it is not spoken or said by the healthcare team, if they judge that that is an outlandish request, then they will be upset about it. And they will go back and talk amongst themselves in the bunker, and they may seethe as they do the CPR, or they may perform something called a slow code, which is also known as a Hollywood code, or a show code, or a light blue code, or a blue light code. These are all nicknames for a half-hearted attempt at resuscitation, and the purpose of it is to please the family while not actually resuscitating the patient. So this is really the ultimate of lack of communication, that you can't even say that I have a serious problem with trying to resuscitate your loved one under those circumstances. And yet, you know, call it the passive-aggressive way of dealing with it. So who's to blame for all this? If you talk to people on the front lines, they will tell you it's because we don't sign advance directives. And I think there's some truth to that. But I have to tell you that that's not always the problem. And, you know, when we talked about that on the show, you know, we had people who wrote in and said things like Adele Elias from Campbell River, BC. It seems to me that you're working from an incorrect premise, she wrote. Many people feel pressured to receive treatment that prolongs life against our will. My 97-year-old mother-in-law had a do not resuscitate order. A day before her death, we found her attached to all the equipment necessary for resuscitation in the emergency department. It was only after I reminded the doctors that she had a DNR that she was permitted to return to a familiar place, which means back to the long-term care facility. In addition to that, sometimes we change our minds as often as attending physicians go on service, and that can be very confusing and bewildering to families. That's not to say that there aren't clashes of views that end up in the court. Most of them don't. This is one that did. You probably remember this. The story of Hassan Rassouli, who went into hospital to have neurosurgery. A post-op infection left him on a ventilator in a near vegetative state. His physicians applied to the courts to remove life support. His family, on the other hand, believing that he is conscious, fought the doctors. It went to the Supreme Court of Canada, which sided with the family, and in fact, he's about to be transferred to a long-term care facility. I wanted to raise the point and emphasize the point that even if we want to offer palliative care to patients at or near the end of life, in fact, 90% of Canadians, it is estimated, will reach a stage in their lives when they could benefit. 70% will not receive it. We don't have enough palliative care. So the best conceptual framework for palliative care won't help if you don't have it, if it's not an option for you. We can talk about hospices, and they're wonderful places. And Ian Anderson died of colon cancer. His wife, Margaret Anderson, started the first hospice here in Ontario, Anderson House. And it's a wonderful place that has a small number of beds, and that's a problem. You know, we need more hospices. We need a lot more. There is something that I want to say as well about palliative care from the standpoint of the emergency department. This is a true story. I just heard this from a colleague. A patient received palliative care for terminal cancer. The patient's usual palliative care physician said, do not resuscitate. The patient arrived at the emergency department of a different hospital with trouble breathing. They called in a different palliative care at the different hospital who said full resuscitation. How do you make sense of that? That's tough. Then we have, and I don't want to spend too much time talking about this, but certainly Harvey has opened my eyes to the whole issue of dignity. You may remember, if you listened to White Coat Black Art faithfully, the story of Nagy Morkos. In his early 50s, he was diagnosed with Huntington's disease. He watched his father die of Huntington's disease, which placed him in a very unique position. He saw what his future would bring, and he ended his own life about a year after I spoke with him the first time. He came back a second time and ended up ending his life about 6 weeks after I spoke to him. It was actually a farewell conversation. He didn't say it because he knew that as a physician, if I intervened, that I might actually get into trouble with the law. And where are we in that debate right now? Well, you know, it was on The Current this week, and actually it's very important that we hear both sides of the story. And what you heard on The Current this week was the story of the misuse of these provisions in countries like Belgium. And I think we need to have a full understanding of what all the implications are. I'm sure you've heard of the story of Gloria Taylor. 4 other plaintiffs applied for doctor-assisted death. Taylor herself received an exception that would have allowed her, if she had so chosen, to have a doctor-assisted death pending the outcome of the case. She ended up dying of natural causes. The BC Court of Appeal recently upheld the federal ban, and that's where we sit in the rest of Canada. As I'm sure you know, in Quebec, things are bubbling. And the reason why The Current did their story earlier this week is because Quebec is very close to passing a law. It would be the first in this country to permit doctor-assisted death. You know, there are many sides. I'm not going to endorse, I'm not going to condemn it. I will say that there have been strong comments on both sides. One that's worth mentioning from bioethicist Margaret Somerville, who said that the Quebec proposal is not balanced and it reads like a pro-euthanasia manifesto. She also has said, can we even imagine teaching medical students how to kill a patient? And that is certainly a strong perspective. The one thing I did want to say about this that I think is worth reflecting on as well is that if you judge by the surveys, while the public may have an increased interest in this proposal, it is not matched by increased interest in the medical profession. And I don't know how you have doctor-assisted death without doctors. And certainly it's something that will make this a very heart-wrenching debate in the years to come. I want to say one last thing about empathy before I close my remarks and we open it to questions. That's a picture of my folks in probably the last good times. It was the occasion of their 50th anniversary. My mom has terminal Alzheimer's disease and she's in a nursing home, and my dad passed away on October the 20th, quite suddenly. My sister and I signed a DNR, and my father had a final ACS, a heart attack. I was with him for the last 6 hours in the hospital, and about 9:30 p.m. He had just been settled onto the ward on a telemetry bed in the cardiac floor, and he asked us all to leave. You know, my wife Tamara, my sister Joanne, and I. And he said, you know, I'm tired and I want to go. I want to get some rest. And you know, it's interesting. I had a foreboding the entire day. That happens when your father's 92 and he has a heart condition. Looking back, I think he would have rather died in his bed at the retirement home. It was not where he would have wanted to die. He would have wanted to die with my mother by his side. Unfortunately, life didn't provide that for him. The last 3 years of his life, and I'm saying this, Harvey, because you got to know the story. The last 3 years of his life was all about losing his independence, losing control of his finances, of his home, of his car, his driving, his mobility, his hearing, his companionship of my mother. And for his last act, he asked my sister and my wife and I to go. And that was 9:30 p.m. And, you know, I wasn't as vigilant and as neurotic as I often am. It's often said that Brian Goldman would study for a blood test. That's how vigilant and neurotic I can be. I had worked the night before in the emergency department, and I'd had 1 hour of sleep in about 48 hours. I had enough of a foreboding to say 3 words that I've never said to my father up until that point in time. I kissed him on the forehead and I said, "I love you." And those were the last words that I said to my dad. And my sister and my wife and I left, and the next time I was awake, I went home, went to sleep. Next time I was awake, my wife was shaking me awake. My sister and my brother-in-law were at the front door, and she had a stricken look on her face, and I knew. And you can frame that in many different ways. But I wish I'd been there, but you know what? It's not the worst way to go. And that final act of will, "You don't need to see me die, I'm okay," is one that I will remember for the rest of my life. That's the way I choose to frame it. In the last instance, he chose an act of will. And it's a reminder to me that we need to listen to our patients. We need to find a doorway to do so. And unfortunately, all too often, the key to empathy is either being a patient yourself or being the loved one of a patient and seeing things from your side of the gurney. I wish it weren't so, but that's often the way it is. And I'll just close with this. Please, 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 sign it, talk about it, don't put it in a safe. Put it out there, talk to your families. You know, is the conversation the 70-40 conversation? You're 70 and your kids are 40? Something like that? Don't wait. Make your death meaningful, just as your life is meaningful, just as your birth was meaningful. Thank you.